morning and welcome to Health Talk, sponsored by Mon General Hospital. This program is designed to provide education on vital health topics to help you take charge of your health. You'll also be introduced to Mon General's committed physicians, allied healthcare professionals, and quality programs and services. And now, here are your Health Talk hosts, Kay Murray and Jim Stallings.
I'm Jim Stallings,
I'm
along
Kay
with
Murray.
Kay Murray. Good morning, Kay.
Good morning, James.
And we welcome today Dr. William McClellan, on staff at Mon General Hospital. Today we're going to be talking about some reconstructive surgery, and we're going to be starting off with hand surgery. Good morning, Dr. McClellan. Welcome to the program.
Hey, Jim. Hey, Kay. Thanks so much for having me.
Good having you here on the program. Carpal tunnel syndrome, when we first started hearing that people were being diagnosed with this, I think it was in the onset of the computer age. As more and more people put data entry into their computers, this repetitive motion problem started to crop up more and more. We started to hear about it. What is carpal tunnel syndrome?
Sure. Basically, carpal tunnel is a compression of a nerve of the upper extremity called the median nerve, which gives sensation to your thumb, your index finger, and your middle finger, and a small portion of your ring finger as well. And basically what happens is when your wrist is dorsiflexed, or like you're going to ride a motorcycle, it causes increased pressure within the carpal tunnel. The carpal tunnel is basically a tight box, if you can view it as a box, where the tendons and the nerve travel through. And what happens is you use your fingers and you do a repetitive motion. The tendons tend to swell, they get irritated, and the box gets tighter. It's an incompressible feature. And so as the tendons tend to swell, they want to compress something. And the tendons are pretty resistant to compression. However, the nerve is not. So they tend to squeeze on the nerve. And when they squeeze on the nerve, it slows down the transmission of the sensory receptors, and basically your fingers go numb. And so carpal tunnel surgery, number one, you can diagnose it with some physical exams or an EMG nerve conduction study. And typically the best result is surgery, whether endoscopic or open carpal tunnel release.
So how would we know if we were at risk for this, or how do we go about preventing it? I mean, this isn't one of those things that's a family history related event, is it?
Not typically. I do see a lot of family members that come in with it, but I don't think it's related to family history. It's most likely related to your occupation or repetitive. I get people who sew a lot. I get people who work on gas wells that use vibratory tools like drills, jackhammers, etc., and a lot of computer users.
So do you go about treating that by having the nerves that go through the carpal tunnel get down to normal size again, or what do you do exactly to relieve the symptoms?
Yeah, typically by relieving the pressure or relieving the inciting event, changing your work habits, changing your activities of daily living. So generally the best way to start out is with a splint, and I typically have an orthoplasty splint made by a certified hand therapist because it gives the best fit. And when you have a good fit on a splint, you tend to wear it. So splinting, you can do an injection in the carpal tunnel of corticosteroids, which has variable outcomes, and then you have surgery.
So again, the symptoms are the numbing on the fingers.
Yeah, and it tends to wake people up, and they tend to say, I have to shake my hand out, in a dependent position, and it gets better and it goes away.
Once we have the surgery, does that mean it's all over for us, or can this happen again?
Typically, it's completely resolved. However, the most common reason for recurrence of carpal tunnel is incomplete release. I tend to do an open carpal tunnel release to make sure that we get a complete release, and it typically does not come back.
This can happen in all ages?
It's typically adults, but it can happen in children. There are case reports of it, but it's very rare.
Kay, did you want to handle the next topic under hand surgery after carpal tunnel syndrome, or do you want me to handle that one?
Go ahead, Jim.
I'm going to try Dupuytren's contracture.
Jim, you've been thrown under the bus.
Yeah. That's right. Dupuytren's contracture.
Yeah, Dupuytren's contracture.
Dupuytren's.
That's why I didn't do it.
ZK, you're very smart. Good job.
I know, beyond that.
Dupuytren's contracture, that is a genetic disease. It's a high predisposition in Northern Europeans and Scandinavians. There's actually quite a few people around this area that have it, and they typically come in with nodules on the palm, which are actually called Dupuytren's nodules. And what will happen is that we don't know the inciting event. It will just start to grow one day. And what will happen is your finger will get drawn down into your palm.
Ouch.
And usually it's the small and ring finger, but it can also be the thumb. It can occur on the feet, and that's called Lederhosen disease. But it's basically a proliferation of a type of cell called a myofibroblast, which causes a contraction. And there are a bunch of different ways to treat this. You can take a needle and rupture the fascial cord. You can, there's an injection now that you can do, which I do not do because there are no long-term results on it. I typically do an open Dupuytren fasciectomy, where you actually open it up and take out that. It usually works very well. However, it can recur.
Is it hardened flesh, hardened nerves, hardened muscle?
Yeah, it's actually a disease of the superficial palmar fascia. A fascia is like a tough, gristle-like material, and the fibroblasts tend to congregate in this layer of tissue. And once you remove that layer of tissue, typically it goes away. However, it can recur on other fingers or the other hand, and it's important for people because typically what I see people that are too contracted. And what happens is, it's called the tabletop test. If you can't put your hand flat down on the table, then palm down, you should come and see me. If the middle joint of your fingers is called the PIP joint. That's the middle one, the middle knuckle. Any bending of that joint, you should have it looked at, because I call the PIP joint the Achilles heel of the hand. Once this joint starts to bend, it's very difficult to get it to move again. So if you do have that, come in, and it's a quick evaluation, and either it's surgery or no surgery.
I'm going to ask.
Can I just ask one question? Can any type of arthritis cause this?
No, the actual cause of Dupuytren's is unknown. There's just a strong predisposition to Northern Europeans and Scandinavians. It's not related that I know of to other diseases.
Rheumatoid or osteo?
No.
Okay.
And that sounds like something. I'm going to show you. I'm going to show the camera a thing on my finger. This index finger right here. I got some kind of nodule or bump that's been growing there for the past year or so.
Does not look like Dupuytren's.
Okay.
The Dupuytren's nodule, if that was in your palm, and typically there are 3 or 4 of them, that would be more predisposed to Dupuytren's. And when you get those, that's like the first step in developing a cord. A cord is what draws the finger up. And typically people complain that they can't put their hands in their pockets, or they can't put gloves on in the winter because one of their fingers is bent. And that's usually the reason why they come in. And by then it's usually too late to get a good result. If you get it early, you can have a full recovery.
Yeah, because this isn't making my fingers bend, and it doesn't even hurt. It's there.
Right. Most common, that looks like a cyst of the flexor tendon sheath. Could be a benign tumor called a giant cell tumor, but it's unlikely. It looks like a cyst.
So maybe I just need to pop it.
Yeah.
Really?
Not yourself.
No. Just take a book, smash your finger. No, don't do it.
A hammer.
Let me do it.
I got a belt sander that does a lot of medical work at home down in the basement. It's 8:42. You're listening to Health Talk, brought to you by Mon General Hospital on WHAR. We'll be back right after this.
This is Mon General's Health Talk. If you have a health-related question, call us now at 304-296-0041.
Our guest today is Dr. William McClellan with Mon General Hospital, and you're listening to Health Talk. So we're talking about hand surgery. We're going to talk about breast reconstruction and eyelid reconstruction. But I'm just wondering, what kind of surgery are we calling this today? It's not cosmetic. Is it plastic surgery?
No, it is plastic surgery. Plastic surgeons are fully trained in hand surgery, and additionally, I did a hand fellowship at Duke University. Specifically, that was an orthopedic hand fellowship. A lot of people show up in my office and they've been referred by their primary care doctor, and they're like, "Why the heck am I here? I'm in a plastic surgeon's office, and I've got carpal tunnel." And so that's part of us just informing the public that we do hand surgery, and I would consider that a reconstructive surgery, such as breast, eyelid, etc., which you're going to touch on, but also can be in the hand. I do many traumas through the emergency rooms, such as saws to hands, tendon injuries, tendon lacerations. I do microsurgery on nerves, so really global.
We had a coworker here at one time, and he still works in town, but he got in a rollover accident in a vehicle, and the car rolled over on his hand and had to have, at that time it was called microsurgery, on his hand, and got almost full use of his hand back. And I thought that was amazing, but that must have been like just real tiny is a microsurgery exactly what it sounds like? You probably have to have it under some kind of microscope, and you're putting nerves back together.
Yeah, so I can reattach fingers, sew small blood vessels back together. We've had people come to Mon General with lacerations where they cut their major nerve to their hands that we can put back together. We can move tissue from one part of the body to another, such as taking a muscle from your abdomen and sewing it into your blood vessel on your ankle.
Amazing. With all this and what you do, it would seem to me there would be physical therapy afterwards.
Physical therapy is really important, and I'm a big believer in hand therapy after surgery. And I just think you get better results. You get moving earlier. Someone pays attention to you. You can do scar massage. And as I have matured as a surgeon, I think that therapy is almost as important as surgery. Generally, when people come in with trauma specifically, not necessarily elective surgery like carpal tunnel or Dupuytren's, but hand surgery specifically is a 50-50 proposition. If somebody comes in and they have a severe laceration to their hand, they're going to need a lot of rehabilitation. I can only put the things back together. If they don't move them, if they're not motivated to get better, they don't have an optimal result.
Yeah, they have to take it upon themselves
Sure.
to get better. Jim did the last subject. I'll try to get this one. Trigger finger. What is that?
Trigger finger.
Trigger finger. It's really big in hunting season. No. The trigger finger is where you get a swelling of the tendon that allows you to bend your finger. And it typically happens at the distal or furthest part of the palm, on the palmar side. And typically you can feel a little bump. If you put your finger on the pad of your hand and you bend your finger, you can feel a little bump there. And typically it gets caught. So over time it builds up. It'll be sore, and eventually it'll get caught down in the flexed position. And many patients physically have to pull their finger out into extension. And typically this can be solved by an injection of corticosteroid, but I generally only do that twice, and usually about 6 months apart, because any more you can risk tendon rupture. The surgery is very straightforward. It's day surgery using a beer block in the hospital or under local, and just simply release a little constricting ring, and it gets better.
Does it always affect the index finger, the
No.
trigger finger?
No, it can affect all fingers. In fact, just recently I released all 4 fingers of a lady.
So it could keep you from perhaps lifting up the middle finger only. Really.
It could.
That might be good for some people.
Except in your case, Jim.
Yeah. When I think of breast reconstruction, I think of women who've had mastectomies or parts of their breast removed when it comes to breast reconstruction.
Yeah.
Is that what you do?
Yeah, breast reconstruction is really important to me. My mom is a breast cancer survivor. I've been on every side of the table, as far as from the student to the patient's family member to the surgeon. I've seen wonderful successes, and I've seen all the disasters. So I feel pretty well adept at breast reconstruction. And I think the nice thing about breast reconstruction is about 7 or 8 years ago, we started doing skin-sparing mastectomies. And, I have to put a plug into Mon General's general surgeons, who I think are excellent. I work a lot with Todd Tolman, Bill Burns, Mark Johnson, Dr. King, Dr. High School. They do wonderful mastectomies. Every mastectomy I scrub with the general surgeon to help them, so that I get the kind of skin envelope that I want to reconstruct the breast, which is really important. And I do immediate reconstruction. I like that the best, because when the woman wakes up from surgery, it's important for her to feel like she's on the road to recovery. And after seeing many patients in personally my mother go through that, I think it's a big step forward for women. And honestly, 5 or 6 years ago, that didn't even exist. And so what we're able to do now is put a tissue expander in at the time of reconstruction, where I lift up the pectoralis muscle and I put a little a piece of material to hold in a tissue expander. And when the woman wakes up, it's not fully done yet, but it's 75% of the way there. So previously, when women had breast reconstruction, a tissue expander would go in flat, and they would have to come back every 2 weeks, maybe 10 or 15 times to have the tissue expander insufflated. Now it may be twice, which is a big step. And so instead of taking 6 or 8 months to be at the final reconstruction, it may be 3.
Wow, you've come a long way with that.
Yeah.
That's great.
When we come back from the break, eyelid reconstruction will be the topic. You're listening to Health Talk, brought to you by Mon General on WAJR.
The doctors, the latest news and procedures. Your local health connection is Mon General's Health Talk. If you'd like to be on the show, call 304-296-0041.
Dr. William McClellan is our guest today on Health Talk. And who gets eyelid reconstruction?
Eyelid reconstruction, it typically occurs after trauma, or it can occur after cancer. Cancer on the eyelid is actually pretty common, and there are a whole variety of skin cancers. I work in conjunction with a couple of guys over at Mountain State Dermatology, John Hancock's and David Carlisle, who are Mohs surgeons. And typically I see a lot of people that initially see them. And what a Mohs surgeon does, and I'm not here to proliferate Mohs surgery, but it's a specialized dermatologist that can remove skin cancer basically under real time. And after they have the skin cancer removed, they generally come and see myself, and during the same day, we repair their defect. So it's actually great for the patient, because typically, if you have Mohs surgery done, if it's too complex for the Mohs surgeon to close, it may be a week or two before you get a definitive closure. And we work so well together, we're able to get it done in the same day. It's actually why I missed the last week on your show. I apologize. But if you have a basal cell or a squamous cell on the lower or upper eyelid, I've taken care of total eyelid defects. You could lose your whole eyelid, which is obviously a difficult structure to deal with. The eyelid is very complex and may take multiple revisions to correct.
Are you, in some cases, replacing the eyelid with new skin?
Yeah, so there's a whole bunch of different ways to do it. You can rob from the upper eyelid to place down to the lower eyelid. That's called a Hughes flap, H-U-G-H-E-S, which is a great way to do it, invented in 1937 by a guy named Wendell Hughes. And that's called a pedicled flap. Actually leave that attached so you're unable to see out of your eye for about 2 weeks. And then I come back and divide it, and then you can put a skin graft on it. You can bring skin down from the upper eyelid as well, called a Trippier flap. But there's a whole bunch of different ways to do it. In fact, one of them we've worked on here with the WVU Department of Anatomy. We developed a periosteal bone flap for the lateral part of the eye for lateral eyelid reconstruction. Was essentially described here in Morgantown.
But you retain your eyelashes for the most part?
Typically not. Typically you lose your lower eyelashes. You can have transplants done. I typically don't do that for the lower eyelid because it's not as important as the upper eyelid. Most dust and particulate matter comes from above the head, so upper eyelashes are much more important.
Now tell me about your videos that are online via YouTube.
Yeah, so a lot of people want to know how this stuff is done, and so obviously with patient permission, we videotape surgeries, and I use them from an educational standpoint because a lot of surgeons want to see how specific things are done, such as our periosteal bone flap, or how a Hughes flap is done, which is a very important reconstructive technique. And then some people just want to know, how is a carpal tunnel done? What happens with a trigger finger? And so we started putting those up and have gotten a great response, particularly for breast cancer. My breast cancer series is not completed yet, but one of them is nipple reconstruction, the third stage of breast reconstruction. And people always want to know, how is it made? And it's a neat little skate flap, and you can see how it's made.
And what should we search for once we're on the YouTube page?
I think it's under, you can look at Morgantown Plastic Surgery or W.T. McClellan,
right.
and it'll come up.
But thank you so much.
And it's on our webpage as well.
Thank you so much for the information this morning.
Oh, you're welcome. Thanks for having me.
Great guest. And our guest is Dr. William McClellan, physician on staff at Mon General. You've been listening to Health Talk, brought to you every Thursday morning right here on 1440 WAJR, brought to you by Mon General Hospital.